Mike Gibson, Raj Kharbanda, and we're talking about the PROTECT-TAVI trial. Talk to us, Raj, about what you did and what you found.
So this was a randomized trial testing the use of Sentinel cerebral embolic protection in patients undergoing TAVI. This was a randomized study, 7,000 patients. So we randomized 7,635 patients to a one-to-one randomization across 33 UK sites. The endpoint was stroke at 72 hours or discharge, completed the trial. And the key outcomes were that in the control group, 82 participants had a stroke. In the CEP group, 81 participants had a stroke. And that meant a risk difference of -0.02, which was not significant. So no effect on all stroke. In terms of disabling stroke, there were 53 participants in the control group with disabling stroke, 47 in the treatment group. That meant a risk difference of -0.2, but that was not significant. So there were no differences in either all stroke or disabling stroke. In terms of other secondary endpoints, including death, non-fatal stroke, and TIA, there were also no differences, with a rate of 3.1% in the control group and 3.3% in the treatment group. The clinical outcome really was that this was neutral. And then we looked at a range of subgroups, including age, sex, bicuspid valve, surgical score, valve type, balloon expanding or self-expanding, the need for pre-dilatation or heavy valve calcium. And there was no subgroup where there was an effect of embolic protection. So this was a neutral trial in terms of demonstrating an effect of embolic protection on TAVI-related stroke, TAVR-related stroke.
The event rates, were they what you expected? I mean, were you powered, and did this reach your pre-specified numbers?
Yeah, so the original trial was powered on 3% stroke rate in the control group, 2% in the treatment group. We had an interim analysis where we revised the sample size up, but the trial was discontinued by the data monitoring committee at near complete recruitment because of futility. There were some pre-specified futility criteria, and those were met with the rates at 2.2 and 2.1%, 82 and 81 events. It was futile to continue on to 9,700.
So large study, 7,630 patients, neutral. What does this mean for practice in the UK?
Yeah, well, look, I think, we cannot recommend the routine use of cerebral embolic protection as an unstratified strategy. We've still got a lot of work to do to understand if there is an effect, for example, in higher risk groups, and whether there's any benefit. But all of that is going to take some time to unravel. We're planning a combined patient-level meta-analysis with the protected TAVI study to get some more insights, and that should give us a cohort of about 10,000 patients from which to draw conclusions. But I think at the moment we're convinced that there is no convincing evidence that we can generate that supports a strategy of routine embolic protection use in TAVI.
Did you have any kind of MRI sub-study to look at any imaging endpoints?
No, ours was a very clinically based study. This was neurological defect persisting for more than 24 hours, and stroke was adjudicated by an independent clinical events committee. So we didn't focus this on surrogate endpoint. This was a clinical trial looking at clinical stroke.
Well, Raj, congratulations to you and all your investigators on a large, well-done trial that informs us, I think, greatly about the potential benefit or lack of benefit of this kind of procedure. Thanks, Raj.
Thank you very much.
And thanks to all of you for joining us here live from ACC 2025.